Welcome to this innovative discussion of meal replacements and their use in your practice. Before I start, I'll introduce myself. I'm John Dixon. I'm an obesity researcher from Melbourne, Australia. My background is that for the last 20 years, I've been studying the effect of weight loss on health, particularly with regard to bariatric surgery, and I'm interested in how we can optimize health outcomes and look for the problems as well as the successes. I think we find in the surgical world we're always interested in what works and what doesn't, and looking for problems is sometimes downplayed. Today, before I start, there's a few housekeeping issues. First of all, there are some widgets on your screen down the bottom that are going to be important to you. You can move them, resize them, and put them where you like, so that you use them later. The quick Q&A widget you should use for any questions that arise during the program, because we will have Q&A immediately following this program. If you have any issues with technical problems during the presentation, please use the help widget that'll get you an immediate response as to the issue that you're having. These slides are available at the moment through review, and what you will find is that the program as you're hearing today will be available in about 24 hours. So remember that at the end of this session, we will have Q&A, and your questions will be answered. So let's dive right into the issue of the important issue of meal replacements in bariatric. So, naturally, I have conflicts, and those conflicts involve the area of pharmacotherapy, dietary, nutritional supplements, etc., and bariatric surgery. That's the world I work in. Importantly, Bariatric Advantage is supporting this program today. Topic involves a meal replacement. How do they work? Why they should be used? How to use them? And I think the most important thing is considering their use in all weight management programs, and I'll provide the evidence for that. What are meal replacements? Well, they're commercially available products designed to replace real food meals. They're nutritionally dense, they're low in calories, and they provide all the essential amino acids, micronutrients, etc., but without excess calories. They replace whole food, so they're powder, they're liquid, they're bars, etc. They're actually regulated by the FDA as food, not as dietary supplements. Use them, they work. And the reason they work, I'll explain to you throughout this program. So I ask you the question, are you recommending meal replacements as part of your preoperative weight loss? If not, why not? Are you offering meal replacements as part of the tools to maintain or to lose further weight following their surgery? If not, why not? Meal replacements are proven to support weight loss and weight management throughout. Well, there are 4 applications to meal replacements, and I'm going to go through these in detail, so don't worry about the blue writing so much. We use them preoperatively, we use them for postoperative weight maintenance, we use them for postoperative modest weight regain, where we're going to look for weight loss, and when we need significant additional weight loss, we will use them as well, and we use a different program for these. Summarizes the use. First of all, preoperative weight loss. The use of meal replacements, in particular very low-calorie diets, has become a standard of care in preoperative weight loss. Meal replacements are important as part of weight maintenance following any weight loss method. And if you want to lose modest weight loss or additional significant weight loss, they also have an important role. This demonstrates the whole process. The important role of very low-calorie diets as a meal replacement type, and I'll go into that later, prior to surgery, then the importance of weight maintenance and optimizing outcomes after surgery, and if there's a need, through weight regain, etc., or poor initial weight loss, to lose more weight. We can go down the pathway of modest meal replacements to generate modest weight loss, or indeed go to an intensive phase using very low-calorie diets to achieve that weight loss, and rotate then through the very low-calorie diet, if necessary, to a low-calorie diet, and then back to a maintenance phase. The importance is that in the post-operative phase or post-weight loss phase, whether it be a diet, a drug, surgery, device, etc., these programs, this circular program, this utilization of meal replacements at any time in the future is something that can be done. View the use of meal replacements in your practice, and I've just put this slide up, which shows, is data from the Labs study in the United States. It was published earlier this year, and it shows the tremendous variability of outcomes for patients who are having a gastric bypass surgery. Indeed, the variability of outcomes for all surgery and all weight loss methods is quite extraordinary. So let's dive into the preoperative weight loss, the maintenance, the modest weight loss, and the significant weight loss, and let's look at the evidence behind that. First, I'm going to look at preoperative weight loss. This is some work we did some years ago. A PhD student of mine, Susie Collis, looked at the use of a very low-calorie diet over 3 months and followed the liver volume quite carefully. She also, this is using the MRI, so we're able to look at visceral fat and general fat, etc. But this is very interesting. If you look at the volume of the liver on the x-axis, you'll see that some of our patients had very large livers, volumes of up to 3.5 to 4 litres. And over the 3 months of the very low-calorie diet program, you can see that for the big livers, and this is the change in weight on the y-axis, the percentage change in volume on the y-axis, and the original liver volume, the key thing is that the big livers dramatically reduce in size. And if you look over to the right-hand side of the figure, you'll see 30% reductions in size in some of those big livers. Now, this is interesting, and that's 3 months of very low-calorie diet. But then she went very carefully at some of the people with bigger livers and serially examined their liver size. And what she found, and what we expected, was that most of the liver reduction size would come in the first couple of weeks, very early on. And we did the first test at 2 weeks. You'll see 80% of the liver reduction occurs in the first 2 weeks. And overall, there's around, in this group of patients, there was around a 30% reduction in liver size at the end of the study, but 24 of that was there in just 2 weeks. If we look at the visceral fat, we can see that there's a gradual loss in visceral fat, but most importantly, by 12 weeks, by 3 months, there is a 25%, almost a quarter of the visceral fat is gone. And of course, you can see the more modest weight loss that the person achieves. So the message here is that most of the liver size will be reduced in 2 weeks. There's for the routine patient, there's no need to do more than 2 weeks of this. But if you have a person with a lot of visceral fat, a lot of metabolic problems, or a very large patient, you can safely use these very low-calorie diets on throughout that program. Why do we expect liver size reduction in the first couple of weeks? Well, almost all of our patients have fatty liver. Fat is quickly mobilized when people are on a low-energy diet or a very low-calorie calorie diet. The carbohydrate stored in the liver is in the form of glycogen, and that involves a lot of water alongside the glycogen. And of course, when the liver fat is reduced and the glycogen is reduced, the liver volume will reduce dramatically. And this happens, as you can see, within a couple of weeks. That's the evidence for preoperative weight loss, and there's absolutely no doubt that the standard of care is to use a proper, very low-calorie diet through that program, because it happens quickly and it happens very efficiently. What's the evidence for weight maintenance using meal replacements? Well, this is a meta-analysis here that shows this meta-analysis it shows a number of studies where people have lost weight through dietary methods, but an extraordinary amount of weight, 12.3 kilograms. And the things that were able to maintain that weight into the future, number one, meal replacements, 3.9 kilograms in addition to what was previously what would be expected to be lost. Drugs work, high-protein diets work, exercise, which we've always been told works beautifully, has a very minor effect. In fact, it wasn't statistically significant, and dietary supplements do nothing. So when you're looking at weight maintenance following weight loss, whether it be surgery, whether it be devices, whether it be whatever you use, the use of meal replacements to follow are a crucial element in maintaining optimal weight loss. Just to follow this up, the Look Ahead study, which was a study designed to examine very intensive lifestyle interventions for people with diabetes in the United States. There are over 5,000 patients in this study. What predicted? Better weight maintenance over time, higher levels of physical activity, greater attendance at follow-up, and using meal replacements. So they're a proven value. Why don't we use them? So some post-surgical patients, and I showed you earlier this variety that occurs in the outcomes. We can have a patient who, like in the orange bar there, the orange group, have a poor initial outcome. Now, what are we going to do? Well, for a surgeon, treating that is surgical. But in fact, we've got to think about what we're really doing. Will they get a better result doing something else? What we really need to do is to think about meal replacements, think about pharmacotherapy, think about other proven things that work. And remember that if you look at the trend on all of those lines, except the black one that seems to cross a few, if you look at the trend of all those lines, there's a nadir, there's a bottom, there's a maximal weight loss and weight regain. When our patients start to regain weight, their concern is that it's a threat and that they're going to put on weight and that they've, inverted commas, failed yet again, and they're going to be on their way back to their old weight. Now, we can reassure them that that's unlikely to happen, but it's a sense of control. They feel that they're out of control. Meal replacements at that stage provide the logical step in control. This slide from the group in Philadelphia, Tom Wadden and his group, and they studied the drug sibutramine back, this is before sibutramine was taken off the market, but the medication alone did very little. When the medication was used with behavioural modification, a really quite excellent result. But when they added meal replacements, look at that weight loss. This is really, really impressive. And yet, we have to say that in this case, the medication and the meal replacements were enablers for a behavioural method of weight loss. So we rely on behaviour, but we know that behavioural change does very little by itself. When you combine medication and meal replacements, you enabled much better weight loss. Now, this is the same as we expect with surgery. Lifestyle interventions do very little for the majority of people, but if we add surgery, we get a beneficial effect. If we add medication, we get additional beneficial effect, and if we add meal replacements. So we've got to use effective therapies, and we've got to put them together to get the best outcomes. What's the evidence base behind meal replacements about their safety, etc.? Well, the evidence base, and there's a number of reviews there that I've put in, and you can look at those references later because they go through it in detail. Better weight loss maintenance. They can be used over long periods of time and intensified if necessary. I've got patients who've been using meal replacements for the last 20 years to maintain their weight. They are safe from the perspective of the liver, the kidney, body composition, and lean body mass and bone. Quite a shock, isn't it? These intensive diets are very, very safe. Randomized controlled trials show that they generate better weight loss than conventional calorie restriction. Their safety profile is very high, and we tend to we tend to be surprised by how well tolerated they are. And I'm going to go into that in more detail shortly. I've talked about meal replacements. I want to now very quickly address the issue of, well, what's a ketogenic diet, what's a very low-calorie diet, and sometimes we get these confused. Now, meal replacements are products that replace meals. Ketogenic diets are low-carbohydrate diets designed to produce ketosis, and as I'll indicate to you, ketosis suppresses appetite. There are ketogenic diets which are not meal replacements. Clearly, people can go onto a ketogenic diet, and generally the diet is fairly high in fat. It needs to be when there's low carbohydrate. Very low-calorie diets are diets that are less than 800 calories, and they are all meal replacements. We don't expect that normal food will be a major part of what people consume on a very low-calorie diet, and most of them are designed to be ketogenic. So they're very low-calorie diet and ketogenic. So let's examine our intensive type of meal replacement, and that is the very low-calorie diet. Very low-calorie diets programs are less than 800 kilocalories a day. They provide all our nutritional requirements. The energy provided by the various products is 500 to 800 calories a day. We like to go up to about 800 calories, and if the product's providing slightly less, we can add some sensible food or some oils, etc. I'll talk to you about that later as to how we can actually use very low-calorie diets. Importantly, the carbohydrates must be kept low and evenly distributed throughout the day so that we can get that ketosis that I'll discuss a little later. And there needs to be adequate protein and adequate quality of protein. This is why specific products are needed. Of course, they need to provide all the daily requirements of vitamins, minerals, trace elements, essential fatty acids, etc. They are designed to produce ketosis. They are designed to use our fat stores. They are designed to change our preference from getting most of our energy from the fat we've stored rather than the carbohydrate we're consuming. I'll indicate the importance of the low carbohydrate shortly. I hear you say, look, I hear this all the time, that, they don't work, and my patients could never stick to them. Rapid weight loss produces rapid weight gain, and hunger destroys any compliance of an intensive meal replacement program, such as a very low-calorie diet. Well, let's address these. First, when we look at a very low-calorie diet, and we want to generate ketosis, and ketosis is a good thing, not a bad thing, we look at the importance of reducing carbohydrate. If we reduce carbohydrate, the liver needs to make more carbohydrate. Gluconeogenesis is important. We also find that we're limiting the carbohydrate supply, we're burning fat, we're producing, fat is our major energy source, we're producing ketones, and with the gluconeogenesis from the liver, we're supplying the brain with the essentials. Ketones are well used by the brain, the heart, and other organs, but particularly the brain. And of course, the brain needs glucose. And so we've got this lovely process whereby burning fat is enhancing the and low carbohydrates, gluconeogenesis, ketone bodies, suppression of appetite. But of course, this doesn't happen immediately. It takes some days to do that. So why are meal replacements, including very low calories, an essential part of your weight management program? Let's go through the 5 key reasons. They work. There's an excellent evidence base. They come only second to surgery in generating sustained weight loss. They are very safe. They can be used with other effective therapies, and they can be used intermittently over the long term to manage a chronic relapsing disease. But they are only effective if they're used properly. And you'd have to say that any program that doesn't use all our effective therapies, including meal replacements, is not a program that's taking weight loss seriously. And I'm sure you'd agree that if you really want to treat weight properly, bariatric metabolic surgery should be part of your program. We need to broaden our horizons and look at all evidence-based effective treatments used together. Here's data from the Australian NH&MRC. You can see surgery produces greater than 24% weight loss. Very low-calorie diets, on average, 14-15% weight loss. And low-calorie diets in a meal replacement form about 6%. Now, I want to emphasize that 5 to 10% weight loss is a great advantage to health. And so we've got to be very careful that we don't work in the surgical world where, 50% excess weight loss is important. 5 to 10% weight loss or 5 to 10% additional weight loss for a patient who's struggling is very, very beneficial. So all meal replacements are useful. You'll see over here on the right-hand side, meal replacements produce the most dramatic weight loss, but they don't sustain that. But you'll see that's the light blue line. It is sustained well, and I'll show you some data on the sustainability of very low-calorie diets. And of course, below we've got the effect of surgery, which sustains weight loss out to 20 years. This is the Swedish obese subject study. So, I've emphasized the importance of ketosis. I've emphasized that ketones suppress appetite. How do we maintain that appetite suppression? Well, we must keep the carbohydrates down, and people will take three days to become ketotic, and they'll go through a really hungry time during that 3 days. But if you then add significant amounts of carbohydrate, there'll be trouble. A latte, for instance, is a friend of mine who he could get away with one small glass of wine, but he couldn't get away with two. This guy had no problem with weight. He was an excellent physiologist. Many of his references are here. But he found 2 glasses of wine, took him out of ketosis when he was on a very low-calorie diet, etc. So just having a bit of pizza, having a bit of bread, having these sort of things, they will put you back in a state where you need 3 days of preparation. How do you know your very low-calorie diet is working? Well, apart from the first week, when of course there's a lot of water lost with glycogen, that's associated with glycogen in the liver and muscles, you'll be losing about 1 to 1.5 kilograms per week. That's the typical early weight loss. Of course, it plateaus later. The other interesting thing, though, is your patient will tell you that their appetite is suppressed. They will tell you that they feel in control, that they feel that they're winning. They'll also provide ketone bodies, and what you'll find is that those ketones will be they'll notice them on their breath, or their partner might notice them on their breath. On the other hand, one of the best ways to indicate that you're in ketosis is to actually use the keto sticks that we use for people with type 1 diabetes, where ketosis is a problem if they've got ketoacidosis. However, in this case, we can just get people to learn how to use that ketones as a way of using the keto sticks as a way of knowing that you're in ketosis. Now, one of the other things that's often mistaken about very low-calorie diets is will more rapid weight loss cause rapid weight regain? And a survey done of Australian dietitians found that only 100% of the survey believed that rapid weight loss would produce rapid weight gain. And really, it showed that only the 100% of a large survey had not read the literature from last century, where they showed that the effect of very low-calorie diets was more long-term. So one of our excellent dietitians did a to prove in a randomized controlled trial that what we knew from last century, from observational studies and so forth, was that very low-calorie diets work, and they do, rapid weight loss is not associated with rapid weight regain. What they did is they took 2 groups of people. They weren't interested in they took 2 paths to achieve 15% weight loss. Okay, so the very low-calorie diet group achieved 15% weight loss within 3 months. Within 12 weeks, 3 months, and the others took 9 months to achieve that level of weight loss. The interesting thing is they wanted to find out, well, once they achieved 15% weight loss, what would the weight regain be like? But the first point is that of those who had the very low-calorie diet, that's the red bars, and the pinkish bars below, 80% achieved the outcome of 15% weight loss. Now, in this very intensively followed group, by 9 months, around 60%, this is completers, achieved the completers achieved the result. You'll see here it's over almost 80% and down to almost 50% of the intention to treat group. In other words, if you use a very low-calorie diet, you're far more likely to achieve 15% weight loss. If we look over on the right-hand panel now, we'll see that once they reach that low level, the weight regain over the next 2 years, that's over about 2 years, was exactly the same. Rapid weight loss does not lead to rapid weight regain. There's many reviews on very low-calorie diets, and the surprising thing is how effective they are, how there's excellent compliance. Now, you know, when I go and talk, people keep saying, well, my patients couldn't use that. Well, all the evidence suggests they can use it, and you can see in Katrina's study that I've just presented, 80% were able to achieve that. In 80% use very low-calorie diets, and we can modify things to even get more people to be using meal replacements in a healthy way. One of the interesting things is the data in this review that was published early this century, and all the studies were done last century, was comparing very low-calorie diets with low-calorie diets. You can see here at 4 to 5 years, the weight maintenance with the very low-calorie diets was 7.1% and low-calorie diets was 2%. Now, just keep thinking, 5 to 10% weight loss is very good for health. 2% weight loss is questionable. And I must say, one of the nice things about using kilograms is that the average people coming into most weight loss programs, other than bariatric surgery, for men and women have an average weight of about 100 kilograms. So in fact, percentages and kilogram loss are very, very similar. The percentage weight loss, the percentage weight that's maintained following a very, very low-calorie diet, in other words, that's lost, which is maintained, is higher, 29 versus 27%, and the percentage weight reductions you can see there. Very impressive long-term weight loss. Hey, why are we seeing this greater weight loss in the very low-calorie diet group and better sustained weight loss? You might ask yourself, how does it work that it works for that period of time? Well, this study actually adds quite a lot to that picture. This is 334 patients, BMI greater than 30, age 18 to 60, large study, very important. What they did, give everyone a very low-calorie diet for 16 weeks, and they achieved weight loss. And then they took one group and said, we're going to get you to intermittently use this diet for 2 weeks, every third month. And another group was randomized to the diet that was actually targeted to a weight regain point. In other words, they lost the weight on the very low-calorie diet, they were starting to put on weight, and they were given a trigger, a personal trigger, that they had to then start to use the very low-calorie diet to keep down below that point. And they were interested in, clearly, the use of meal replacements and very low-calorie diets as an ongoing event. What happened? The mitten group, they lost 7 kilograms over that period of time, and the on-demand group were able to achieve after 2 years a 9.1 kilogram weight loss. Translate those, very similar to percentages. The interesting, so there was no significant difference between those two, although it looks like the on-demand, that is the targeting a point to go back and have another meal replacement, it was the better way forward. But you'll notice down the bottom there that the males responded really only to the on-demand, and they weren't actually using clearly the intermittent use. They were able to achieve 14.5 kilograms versus 4, the males versus 4 for the men in the intermittent group, and this is both groups have very significant, clinically significant weight loss at 2 years. Practical, let's look at how we use very low-calorie diets. First of all, the indications, contraindications. They are suitable for people with BMI greater than 30, a BMI greater than 27, with medical comorbidities or obesity-related comorbidities. They provide the standard of care pre-surgery. Post-surgery, they're a natural way of reducing caloric intake, and they can be used. They can be used by providing quality nutrition without additional calories. Contraindications include pregnancy, older age, recent myocardial infarction, unstable angina, etc., major organ failure, some of the severe psychological and psychiatric disturbances, and there's some more detail on that, alcohol, illicit drug use, and there's a lot of cautions with type 1 diabetes, gout, impaired renal function, etc. Using very low-calorie diets is something that is like using a medication. You need to know indications, contraindications, precautions. You need to know how to manage it. I've already, in fact, if you don't use these tools properly, they won't be used properly, and people tend to get frustrated without the assistance. So here are the contraindications again in detail, and I won't go through each one. And the precautions, the increased likelihood of developing gallstones as you get with bariatric surgery and weight loss, and etc. Now, importantly, you can find a lot of information about very low-calorie diets and specific use with each of these conditions in the literature, and it's important to really know this tool backwards before you embark upon that. There are common problems that occur with very low-calorie diets. In fact, rapid weight loss of any type. Dry mouth is often a problem, constipation, you'll know this from your bariatric surgical patients. Headaches, dizziness and fatigue often occur in the first week during that fluid shift, that dehydration period with the glycogen, etc. And it completely changes after that, and people need support through that time. Orthostatic hypotension can occur in that first week. They get up and they feel lightheaded. It can be a little bit difficult for some people to exercise during that first week, but by 2 to 3 weeks out, they're exercising as well or better than ever. Of course, with weight loss, we're going to get cold intolerance, we're going to get dry skin, we may have menstrual irregularities occur, there can be hair loss that's associated with the weight loss, and of course, patients will complain of the halitosis, which is a ketosis, which is actually what we want. We want the ketones there. We do sometimes see muscle cramps. Anemia is very unusual. These are well replaced. We don't expect nutritional deficiency, but we need to listen to a patient's symptoms and look at this. Gallstones can occur, and we use oil, olive oil, etc., is part of the diet to try and contract the gallbladder and reduce that risk. As I've indicated earlier, body composition and bone are usually tolerate this very well. If you've got an osteoporotic person, you'd be obviously interested in tracking their bone density. But it's a tool you need to learn to use, and very effective and very safe. A few things that you need to learn about. Simple practical things. I think when the patients are complaining of the bad breath, we can use non-calorie mints and chewing gum. You know how to deal with the constipation of post-bariatric surgery and the dry skin, etc. And importantly, these things occur without there being any sense of nutritional deficiency. A friend of mine really promotes the use of chicken or high-quality protein to get through those first few days. If you're not going to have carbohydrate in those first days, when you're that's that 3-day challenge when you go onto a very low-calorie diet, he says get a chicken, put it in the fridge. You can have it when you like if you get hungry in that time. And yes, he's even left the skin on so that because that's primarily fat, and people would do well. It can't be a stuffed chicken. There are other sources of protein to help those people out for those first few days. Now, how do we know that this type of diet reduces and ketosis reduce hunger? Well, you just ask your patients what they're like after 3 days, or tell them to have some pizza or some bread and see how out of control they feel. But there's actually more. We actually know that this suppresses appetite. This wonderful group that I have the pleasure of working with here in Melbourne have done more work on this, and they did a very clever thing. They put people on a very low-calorie diet for 8 weeks to lose weight, and then they actually they gave them they gave them more carbohydrate and a normal diet, but kept the calorie intake exactly the same for the next 2 weeks. And they did hormonal studies when they were ketotic and 2 weeks later when they weren't ketotic. And I know it's a complex study and I'm going to show you studies here, but importantly, if we look at the first one, this is the glucose after a meal. And you notice the glucose after the meal. This is baseline, the solid line. This is the dotted, the dashed line is the 8 weeks, and the dotted line is the 10 weeks. We'll see the glucose during the ketogenic stage stays higher after a meal. Hey, good fuel. So they're on a low carbohydrate diet, but the postprandial glucose stays up. Look at the non-esterified fatty acids are up higher than baseline. They go back to normal when they're 10 weeks. And we see here the ghrelin levels, they don't go up. They should go up with weight loss to get you hungry again. They didn't rise at all. They did rise 2 weeks later when they were not ketotic. And this is amylin over here. Essentially what's happened, this is like bariatric surgery. The nutritional levels stay high to suppress appetite. The hormones change in a way that is not expected to make you hungry and put on weight. It was really a very nice indication as to now there are very clear reasons why it suppresses appetite. This is an interesting study where they actually gave people, this is ad libitum diet, so they could have as much as they liked, ad libitum diet of a high protein, low carbohydrate ketogenic diet and a modest protein with carbohydrate, not ketogenic diet. And these were men in a residential environment and they had a crossover. And it's really interesting when you see that they were on the ketogenic diet, generally their energy intake, this is energy intake and this is the time that they're on it, the days. You can see the energy intake on the ketogenic diet versus the non-ketogenic diet was lower. They ate less. They could eat as much as they like. This is their daily hunger. You notice there, over the first 3 days, there was no difference. Then suddenly they separate and stay separated. Less hunger on the ketogenic diet. And of course, what would we expect for weight loss? This is allowing to have as much food as they like, but on the 2 different diets. So the practical tips regarding very low calorie diets and meal replacements. Adherence is the key. Motivation will be the greatest support for our patients. They will lose weight quickly. They will do very well. The 4 phases of the program are important. Shrinking the liver, weight maintenance, modest weight loss. Remember that you could cycle these. We look at how to help people out, particularly if they're in an intensive phase of a meal replacement, a ketogenic meal replacement, then hunger and side effects for the first couple of days. Help them out through that. Tell them what to take with them when they're out. Taking a bar with you instead of having a different type of snack is important. The use of yogurt, low-calorie fruit, etc. Your dietitians know all this, and there are great websites to get information for the practical ways of giving people tips as to how to remain on their meal replacements and very low-calorie diets in social circumstances. Importantly, we can see now that meal replacements and very low-calorie diets are becoming mainstream. They are an important part of the toolbox. They should be used, and there's a number of manuscripts that really support them. This is a Stephen Hounsfield one. The review supports the use of meal replacements, particularly in a beverage form. They are effective, safe component in the use in the clinical setting. And here's some more recent details from our dietitians in Australia. 99 dietitians were surveyed. These are ones used in managing bariatric surgical patients. Most recommended one of 2 different meal nutrition strategies preoperatively. In other words, they were using diets preoperatively, 74% of them, and 69% of them actually used very low-calorie diets. So for people who had no faith in them initially, the vast majority now are using them. And many practices use them, and they don't have dietitians involved. Now, in summary, remember the 4 applications of meal replacements: shrinking the liver, weight maintenance. Yes, it helps in weight maintenance. When you want to go into an intensive phase and transition through a low-calorie phase, or when you just need that modest additional weight loss or control by going to meal replacements in a in a less intensive phase. The maintenance phase might use one meal replaced a day. Some of my patients actually replace two. The intensive phase will be the very low-calorie diet, ketogenic diet, and the modest weight loss phase will be 2 to 3 meal replacements a day. Get to know the product, get to know how things are going with that. So my final, when it comes to all these problems that people have with meal replacements and very low-calorie diets, they don't exist. They're a figment of imagination. And one of the most important things that we have when it comes to bariatric surgery and obesity and managing weight in our patients is that most of what people believe are myths. Truth hardly gets in the way of a good story. So it's important. I hope you've got a bit of a different idea of meal replacements. Now, this is the end of the talk. In a few moments, we will have a Q&A. Please use the Q&A box to ask questions. If we can't answer them in the next few minutes, we will be available later. We will be able to respond to you following this program. Thank you. Hi there. Well, that was a very detailed discussion, and I'm sure you have plenty of questions. If you could type them into the box, I'll try and deal with them as they come in. One question that has arisen is the use of very low-calorie diets preoperatively, and that is the question of how long you can use these diets preoperatively. One of the most important things is that while we saw the liver shrink within 2 weeks, and many practices will use very low-calorie diets as a standard of care for 2 weeks for everyone, it's common for bigger patients, people who've got that beach ball belly, or are known to have major metabolic problems, to continue the diet longer. And so what we find is that we can use them for many months. And indeed, if you've got a patient who is supersized and they're doing well on the diet, you can continue that diet over a period of many months. In fact, we've had situations where we've used a semi-intensive program for more than 12 months so that we can really get a patient in the best shape for surgery. So don't be afraid to use it. Why do we use it for 2 weeks and not 1 week? We didn't do our study in 1 week, but the main thing is that in the first week when you're on a very low-calorie diet, there's an adaptive phase. That's the time when you become ketotic. The liver shrinks rapidly. There's a period of dehydration, often tiredness. It's a period when people complain sometimes that they're a little bit, they're a little bit, that they're stressed with exercise and so forth. By 2 weeks, you've adapted to the diet beautifully, and you're in a much better shape to have surgery. So I think it's we would look at 2 weeks as being the minimum. I have had a question also about the content of meal replacements, the dietary content of meal replacements. Meal replacements are designed to replace meals, whereas very low-calorie diets are meal replacements, but they're specifically designed to replace everything. So there's a different structure. The macronutrient composition of meal replacements can vary considerably depending on what the aim is, and people have different views as to what macronutrient composition is ideal for weight loss. But when it comes to ketogenic diets, when it comes to a very low-calorie diet, ketogenic diet, it's the restriction of carbohydrates that is crucial, and the amount of carbohydrate that needs to be restricted to generate ketosis varies from person to person, and I see this is one of the queries. Some people will become ketotic when their carbohydrate intake drops below 100 grams a day. Others will need to go down to 60. etc. And I find with my patients who aren't becoming ketotic and aren't doing well on the diet, having struggles, I get them to use keto sticks so that they can tell themselves, that the diabetic type looking for ketones in those with type 1 diabetes, to see how they're going with that. So there's sort of some tips regarding that area. So I think you'll find that that those practical things, one of the most important things is with regard to the use of very low-calorie diets is to read a lot about them, learn how to use them. I think you'll find them very useful. Meal replacements across the board, terrific. Use them, but get to know them. And unless you get to know them and get to love them, you won't be able to impart the joy of using them to your patients. So I know that was a quick wrap-up and questions. We can answer other questions that you might send in, but thank you very much for attending. Thank you very much for being part of this program, and I wish you all the best with your weight management practices, and hopefully you'll increase the use of meal replacements and very low-calorie diets over time. Thank you.